Good morning, everyone. I want to thank Aspetar for inviting me. Philippe, thank you very much. It's an honor for me to be here, and I would like to discuss with you briefly the role of scapular rehabilitation with the specific attention of translating scientific evidence into practice. Now, let's start into the clinical practice. I want to show you some videos of a young gymnast. He was a talent at that time. He was 12 years old, and he was training for about 40 hours a week. To be the best in Belgium, at least. And so that's what happens with his scapula when he's moving his arms. He was having some shoulder pain for 4 months now. And as you can see, he has a large scapular dyskinesia on both sides, but in particular on his right side. And like Ben mentioned, it's not easy sometimes to recognize a specific type, but I think he has all 3 types. So when he moves, it becomes worse. And as you can see from the general condition of this child, he's not very weak because he was training so hard. So then I asked him, can you show me in the gym what is actually causing your pain? So this was one of the exercises that was hurting him. And you should, of course, look at his scapula, in particular when he is down. Not this time, but now this time you will see it. So as you can see, his scapula are nearly beside his body. So he's really hanging on his arms and standing on his hands a whole day for 40 hours a week with a scapula that is not fixed on the thoracic wall. So I think it's obvious that there is a need for a science-based scapular rehab program. Recently, we published a paper in the BGSM in which we propose a kind of a clinical reasoning algorithm that has to be a guidance in the clinical reasoning of the therapist when he performs his scapular rehabilitation. And I want to propose it to you bit by bit. Basically, the scapular rehab algorithm can be divided into 2 parts, an upper part and a lower part, and then also a left and a right part. In the upper part, I try to summarize the problems that can cause scapular dyskinesia, with on the left side the flexibility problems, and on the right side the muscle performance problems. And to compare it with the little sea lion, on the left side it's like the sea lion has some ropes around his neck. He will never be able to stabilize the shoulder. And on the right side it's like the sea lion has no grip on the floor, so he has no possibility to move. When we look a little bit more into detail on the left side, we see that flexibility problems can be situated in the scapular muscles, in particular the levator scapulae and, as mentioned before, the PECT minor. But also the glenohumeral structures, in particular the capsule and the posterior cuff, can cause scapular dyskinesia when they are tight. On the right side, you see the lack of muscle performance problems. And also here we can divide them in 2 kinds of problems. Either we have a muscle control problem or a muscle strength problem. In a muscle control problem, it means that maybe they are strong enough, but they don't know how to work and how to work together. And on the right side, they do know how to work together, but they are not able to bear the load that they're supposed to load during daily life. In the lower part, I tried to summarize some guidelines for rehabilitation with stretching and mobilization on the left side and neuromuscular coordination and strength training on the right side. So when we look at the left side, we see that indeed flexibility problems need to be mobilized and stretched. And we have a large amount of techniques to do that, from manual stretching to home stretching programs, soft tissue techniques, including, for instance, dry needling, manual mobilizations using the accessory movements of the manual therapy, and of course also mobilization with movement. On the right side, depending on the problem, we have different pathways, and I will come back to that later. So we start on the left side. And the first thing I want to tell you something about from a scientific but also from a clinical point of view is pectoralis minor stretching. If we look into literature to the golden standard of stretching of the pectoralis minor, the paper that was published on that by John Borstad showed that the so-called open door stretch, where you put your arm in the abduction external rotation position and then go to horizontal abduction, is the best way to stretch the pectoralis minor, and that is based on a study on cadavers and on healthy subjects. But of course, from a clinical perspective, in real life, we have a problem here because our patients, they have pain in that position. That's why they come to see us. So very often in the clinical practice, we do it like this. This is a direct manual stretching in which we put our thumb up on the coracoid, and while breathing out, we push the coracoid backwards. By doing that, we directly stretch the PECT minor by pushing the scapula into the posterior tilted position like Ben was showing us. The big problem, of course, is this as good as the golden standard? Can we use this technique with an equal efficiency as the open door stretch? Well, we did a study on that. It's not published yet. We're still working on it, in which we measured the pectoralis minor length according to the method of John Borstad. It was done on a group of adolescent swimmers without any complaints, and then they did a swim session. And after the swim session, we measured the pectoralis minor length again, and we divided them into 2 treatment groups. One of them got the angular stretching, and the other one got the direct manual stretching. The main results of the study was that immediately after a swim session, there was a decrease in the pectoralis minor index, which is the normalized pectoralis minor length. So that means that an immediate effect of a swim training session is at least a functional tightening or shortening of the pectoralis minor. But after one session of stretching, there was a normalization of the length in both groups. So conclusion of the study was, yes, indeed, pectoralis minor somehow is influenced by one training session of swimming, but we can reduce that by using either of the 2 techniques. So the clinical conclusion could be, so use the open door stretch in a self-stretching program in healthy swimmers, but you can use the manual stretching in patients. Back to the algorithm, I would like to discuss a little bit more the stretching of the infraspinatus or the posterior cuff and the posterior capsule. Now, what do we already know from posterior shoulder stretching? We do know from some time, amongst others from studies from Phil McClure, that the sleeper stretch as well as the cross-body stretch improve range of motion in healthy subjects after a 4 weeks self-stretching program. Within this study, a slight advantage for the cross-body stretch, but they both were effective. From some other studies, we know that additional manual mobilizations improve range of motion more compared than if we only would stretch them at home. So as long as you want to have improvements in your patients, it's better to do some additional mobilizations. And we also know from a study from Tim Tyler that improvement of range of motion is related to the reduction of symptoms. He looked at a group of overhead athletes with GERD and symptoms of impingement, and he stretched them. And after a period of stretching, he found that those athletes that had increased range of motion also had a decrease in symptoms. However, those in which stretching was not effective also kept their symptoms of impingement. Now, one of the questions we have here is, what is the mechanism? If stretching works in patients, reducing the symptoms, why is that? Well, we don't know, but we maybe did a first step in examining the relationship between symptoms and range of motion and stretching by performing the following study. That was published last year, I think, in the American Journal of Sports Medicine. We measured 2 things. We measured with ultrasound the acromohumeral distance in 3 different positions in between 0 and 60 degrees of abduction, and we measured range of motion into internal rotation. We compared the dominant with the non-dominant side in a group of healthy people with GERD, so the inclusion criteria were 20 degrees, I'm sorry, that's an error, 20 degrees of difference in the left-right. We had actually 2 research questions. One was, is there a relationship between GERD and the acromohumeral distance? And the second one was, can I do something with stretching? So we, in the intervention in the study was a 6-week home stretching program consisting of the sleeper stretch. The first result of the study was that indeed there was a significant difference between both sides regarding the acromohumeral distance, telling us something about the suprachromial space, meaning that in all 3 positions, 0 degree, 45 degree, and 60 degree, there was a significant decrease in the acromohumeral distance. Interestingly, after 6 weeks of stretching, performing the sleeper stretch, there was not only an increase in range of motion, we knew that we could expect that, but there was also a significant increase in the suprachromial space. And maybe that's the reason why stretching might reduce the symptoms. So far for the left side of the algorithm. Now going to the right side, I already told you that depending on the problem, if you have a control problem or a strength problem, there might be different pathways. However, in general, we all say, and that was also already stated by Ben Kibler previously, we all say that we first have to correct the scapular position. And we do that by performing conscious exercises of repositioning the scapula. One of the exercises that is popular and is published by Sarah Muttram from the Kinetic Control Group is what we call the Scapular Orientation Exercise. It's an exercise in which we teach to the patient to perform a corrective movement of the scapula. She found out, performing 3D analysis and also EMG analysis, that to start with, subjects are indeed able to perform consistent movements into posterior tilt and upward rotation. So if you teach that exercise to your patient, you will indeed that will result in an upward rotation and a posterior tilt necessary to avoid impingement. She also found a small but significant increase in the muscle activity in the trapezius, and there was a high correlation between the assisted and the non-assisted exercise, meaning that we can teach that to the patient, and then tell him, do that at home, and you will have your result in a week in scapular correction of the position. Now, in the meantime, we published some exercises ourselves with the purpose to increase the strength in the lower and the middle trap with simultaneous inhibition in the upper trap. That was the main purpose. So in our follow-up study, our research question was, would it be of an additional value to add this scapular orientation exercise to our exercises? So in general, is it good to first correct the position and then perform exercises, or do we just say, do the rowing, do external rotation, whatever? And indeed, when we compared the basic exercise with the exercise with the scapular correction, we found for at least 2 of the 4 exercises a significant increase in the activity in the lower and middle trap. So if you perform an exercise, for instance, in this case, external rotation, a side-lying position, it's important that before that exercise you really correct the position. Otherwise, you have not sufficient activity in the lower trap. Now, after this basic exercise, most of the time we choose our exercises in view of the problem. When we have control problems, we have to find exercises that somehow suggest some better control. Whereas where we have strength deficits, we have to strengthen the muscles. So first I go to the advanced control during basic activities. Now, the basic thing here is that we always have to try to find an exercise in which we minimize the scapular dyskinesias. So your patient is standing there performing movements, and our goal is, what exercise can I do to reduce that? I'll give you one example. When you look here at this patient, she was referred to me for scapular dyskinesias on a functional base, so all imaging and further examinations were negative. And as you can see, in particular, when she comes down, she has no control at all of the scapular movements. So she goes into that type 1, has a bad feeling, has clearly dyskinesias based on muscle patterning problems because there was no structural deficit whatsoever in this patient. So if I would do that exercise, for instance, as an exercise at home, it will never get better. So we have to look for exercises with less scapular dyskinesia. And this is an example. Now I ask her to push slightly into the ball and to perform a movement of forward flexion in a closed chain. This is called the bench press, the bench slide exercise. As you can see, it's not excellent, but it is better. So this is the exercise that she has to do, and after sometimes also against resistance of a TheraBand. Now the question is there any evidence of that kind of programs? I have to say no, because the big problem is that we cannot standardize this program. Every patient will have another set of exercises, and it's our major goal to find the appropriate exercises. We do have some evidence, however, on the right side of the algorithm. In the strength training, one of the first goals should be that we strengthen the weak muscle with inhibition of the hyperactive muscles. And from several studies from the scapular groups, we know that the lower trap and the middle trap is weak, serratus is weak, however the upper trap is very hyperactive. So a few years ago, we published these exercises to just go from A to D. The movements were side-lying forward flexion, side-lying external rotation, prone external rotation with horizontal abduction, and prone extension. All exercises that are in a lying position, probably because then we shut down the upper trap more. This is only the first phase of your rehab before going on to the more functional exercises. But the question we now had was, are there any results? Because I suggested to be exercises appropriate for restoring the balance. So we did a study, first of all, in healthy people. And we found in that study, if you give an exercise program consisting of the trapezius, but also some serratus anterior exercises, to a healthy group of swimmers again, and you measure the isokinetic muscle strength into protraction, retraction, there was a significant increase in strength and also in muscle balance and endurance after a 12-week program of scapular exercises. In the meantime, another group from Italy, from Giovanni Merola, they did a study in which they looked at the effect of scapular exercises to the muscle strength of the rotator cuff, and they measured isometric strength of the external rotators. Their main result was that a 6-month program of scapular retraction exercises improved the infraspinatus strength in volleyball players, which is even more relevant because then you show that performing scapular exercises, you strengthen your shoulder. And then finally, we did a study in patients. We looked at patients and we examined a 6-week program consisting of the 4 exercises. We looked at the number of variables, but in this paper that was published in AGSM also, we looked mainly at the EMG activity. And the main result was that during daily activity, for instance, during elevation of the scapular plane, under the same load as before the training program, there was a significant decrease of normalized muscle activity, in particularly in the upper trapezius, meaning that we use the muscles in a more efficient way. Now, last but not least, I want to tell you something about the advanced control during sports movements. We all know from literature that we should try to integrate kinetic chain into the shoulder rehab exercises, and Ben did an excellent job of suggesting that. We also should focus on open and closed chain exercises, and we should challenge sport-specific position and movements. And as a researcher, my question was, is this all true? Is there a value of kinetic chain into shoulder exercises? Now, we did 2 studies on that. One in closed chain, in which we played a little bit with positions of the legs and the arms in the push-up plus exercise. And we did a study in the open chain. We performed the rowing movement under several conditions. Regarding the closed chain exercises, we found that if you extend your contralateral leg, you will have an increase in middle and lower trapezius activity. So when you create a diagonal in your closed chain, you have an advantage of muscle activity in the shoulder you want to train. The same result was found in the open chain exercise. It seemed that compared to a lot of other positions in which we performed the lunge position, squat position, unilateral stance, there was one position that has better results, which is standing on your contralateral leg. So here again, when you stand on your contralateral leg, you have a diagonal pattern, which probably improves the activity in the trapezius. And that paper was also published in 2012. So to end up this talk, I want to say something about the influence of pain. The question is, what is first, the scapular dyskinesia or the shoulder complaints? And in this case, what is important? Should we train without pain, or can we allow some pain? So in order to try to find out the relationship between scapular muscle activity and pain, we performed a study in which we looked at the influence of the experimentally induced pain in the supraspinatus on scapular muscle activity. So we performed ultrasound-controlled pain induction into the supraspinatus, increased the pain up to 6/10, and then we performed elevation in 3 planes, looking at the timing of the muscle activity and the level. Now, this is a busy slide, but I will explain to you. This is before pain, during pain, and 20 minutes after pain. This is the order in which the muscles are active, the first muscle, second one. And this is the number of subjects in which that muscle was activated, first, second, third, or fourth. Now, if there is no pain, you see a specific pattern. At least 10 of the subjects, 10 of the 20, they have first activation of serratus, followed by upper trapezius, lower trapezius, and then middle trapezius. And that's a pattern that somehow is the same as some other studies, but not totally. Now, what do we see under the pain condition and 20 minutes after pain? There is a predominant serratus and anterior activation prior to the other muscles, and there is no real pattern anymore in the trapezius. So there is change in the muscle patterning caused by pain. When we look then at the level of activity, we see a significant increase of serratus anterior activity during the forward flexion movement. So we expected actually a decrease, but you always have to live with the results that you find. It seems that the serratus somehow compensates for the shoulder pain. And also 20 minutes after pain, there was significant changes in the levels of activity, but it was probably not clinically relevant because it was less than 3%. But we have to say that pain indeed does change scapular muscle recruitment, but there is a need for more studies on that level. So as a take-home message, I would like to repeat to summarize that manual stretching of the PECT minor has positive short-term effects. Increased acromiohumeral distance is found after posterior shoulder stretching. Adding conscious scapular correction increases muscle activity during exercises. The program results in strength gain in scapula and in the shoulders. Diagonals seem to be in favor of scapular muscle recruitment, and we have to take into account that pain can change the muscle recruitment. Thank you very much.